Hi everyone. Thank you so much for joining us on our webinar this evening. Really excited to have Millie talking us through aligners. Very quick introduction. I'm Hannah. I'm a dentist myself. I'm one of the founders of Kiroku. We started the business because I was so stressed with how much of my time was spent writing notes, writing patient documents after appointments. And so we created Kiroku to try and streamline that process and allow you as the dentist to focus on the thing that you trained to do, providing care to patients. So if you haven't heard of Kiroku, we provide AI-powered software to help you write your clinical notes in a fraction of the time. And I think Millie is going to be showing you how she uses it as well. We're really excited because we've quite recently released Kiroku Docs, which, as well as helping streamline note-taking, allows you to create any patient-facing document from your notes in Millie. And in situations like aligners, when you want to have really kind of belts and braces, consent, and information provided to patients, a product like Kiroku Docs can really help sort out so much of that work for you. If you are interested in giving it a go, and Millie will be telling you a bit more about it in the webinar, please sign up for an account. You just need to go to www.trykiroku.com, and on the website, you'll see a button that says try for free. That'll allow you to sign up for a 14-day free trial to get using it, see how you find it. And if it's useful, then you can go ahead and subscribe to the product. Any questions, I'm very happy to answer them at the end. But now, far more importantly and interestingly, I'm going to be passing you over to Millie, who's going to be talking us through aligners this evening. Thank you, Millie.
Thanks, Hannah, and hello, everybody. It's lovely to be with you here tonight on this rather cold and wet Tuesday evening, but hopefully you've all had a good day and you're in the warm now, having dried off after your commute back from work if you were on the commute today. So tonight we're going to look at going beyond the smile and the impact of clear aligners, and we're going to think about how we can use clear aligners to create more than just a nice smile, and how an assessment, so the assessment that we do is so important. And we're going to go through the orthodontic assessment as well, so we'll have a look at the different components of that, and also how we can use Kiroku to really streamline everything. So just to introduce to you myself, my name's Dr. Millie Morrison, and I am a general dentist, but I really only do clear aligner therapy now for patients at different practices in and around London. I have been educating on clear aligners since 2018. And found a real passion for it. And it has really led me to love going into work and really enjoy getting that job satisfaction in terms of what I can give my patients. But it hasn't always been, a clear, easy journey. To begin with, I really didn't like clear aligners. In fact, I found them quite difficult. I didn't really understand what I was doing, and it took me about 18 months before I really decided that actually, no, I am going to do clear aligners. And I wanted to actively start doing more clear aligner therapy. And this meant speaking to patients in a very different way. And we're going to go through that, and how I brought that into the practice, or into my practice I was working at the time, to then going on to being quite successful with clear aligners and introducing them to the practice. So much so that through my education journey as well, I'm currently doing my master's, just got to finish off my dissertation in the next couple of months. And last year, I also launched a mentoring program to help dentists get confident with clear aligners, and basically give everyone what I wish I'd had right at the start, so I could have put my best foot forward right from the very beginning, rather than making the mistakes and going sort of round in circles in some parts to get to where I am today. So aims and objectives. So I really want to look at what else aligner therapy can do, and how we can use aligner therapy to improve patients' oral health, aesthetics, long-term stability, and not just physical, but also the psychosocial side of things as well. We're going to look at an assessment of the patient and how we can really easily incorporate this into our daily workflow, so it doesn't take ages more. It's something that we should all be doing, so that we're really being very proactive with our patients, and from doing these two things, how we can treatment plan better. So, not thinking about each individual tooth, but trying to think of the mouth as a whole. And really, the reason I'm so passionate about this topic is because I really don't believe that we look after teeth. I feel that teeth are a very small part of our job, and actually, we're really here to look after people. And I think that for a lot of the time when we are being trained and when we first come out of university, yes, we might say hello to our patients and we'll talk to them, but we're very keen to look at their teeth as quickly as possible. And we talk to the patients about their teeth as much as we possibly can. And sometimes we forget that there is a whole person and there's something else attached to those teeth. And each person that walks in has a different story, has a different goal, has a different life and different experiences, that actually, if we take the time to learn and understand, it means that we can really serve them in the best way, because that's what we're there to do. We're there as healthcare professionals. Now, I really strongly believe that us general practitioners are in such a wonderfully unique position, because we can assess, weigh up, and deliver multiple disciplines to a very high standard. And it may be that you are happy to do every part of the journey for the patient, from perio, root canal, surgery, ortho. You can do all the disciplines. However, some people like myself may decide actually they don't want to do root canal treatments anymore. You're going to focus on different bits. But the fact that we understand that discipline so well still, and we still maintain our knowledge, means that even if we're not doing it ourselves, we can actually still assess, and we can give the patients very thoughtful and well thought out options that they can then go and consider. So we really are the cornerstone of multidisciplinary dentistry. And I feel like this is something that we should be really proud of, because we really do get to see the patient, get that rapport with the patient, and really understand what the patient wants, and we can then help the patient get what they want. And I like to think of us as, so if I see a patient for the first time, even if I'm not doing all of the work, I will be that patient's point of contact. So if they've got a question, or if they've got something that they're unsure of, or if someone isn't quite sure of the chronological order of how things should be done, I will be there to look after the patient and make sure that they're going through their journey correctly. Of course, with reception and TCOs, but it's always nice to have sort of that dentist figure there looking after the people as well. So I think we're in a really important place, and I think that we do such fantastic work, and sometimes that message gets a little bit drowned out. So I always like to start with that, because what we do is important. And if we look beyond the smile, if we look at what we do for our patients, it's truly amazing. It's truly fantastic. So this is Basra, and Basra came to see me, and she wanted her teeth straightened. And she wanted her teeth straightened because she was embarrassed. She was embarrassed about the way she looked. She felt that her mouth smelt, and she was a teacher, and she just had let things spiral out of control. Because what happens when you're embarrassed, you don't want to show people, you don't want to talk about it. And slowly and surely, what happens is you spiral until you get to a position where you still don't seek help, or hopefully you do seek help. And Basra did seek help, and thankfully she landed with us, because she was such a wonderful person, such a wonderful patient. And I think a lot of us, if we saw Basra walk in asking for tooth straightening, we would maybe roll our eyes a little bit and be like, well, of course you can't have that. Have you seen the health of your mouth? And I understand that sentiment. However, there are a few things going on here. So yes, we've got really severe periodontal disease. We've got active apical pathology. We've got active caries. But what else do we have? We can see that we do have some crowding in the lower arch, but we've got spacing in the upper arch. And look at the palatal aspects of those upper central incisors. Now, what you can't see from photos, but what you can see when you're in the patient, when you're doing the checkup or doing the examination, is that actually there was fremitus on that upper right one. So every time we Basra bit together, that central was moving. And over time, It was moving and moving and moving. So yes, we did have the conversation that we needed to get health first. But actually, one of the things me and my periodontist agreed on is that whilst we could control as much as possible the periodontal disease, having that active traumatic occlusion means that we may never get full sort of maintenance level of periodontal disease, because actually, it's sort of that chicken and the egg. What came first, periodontal disease or the occlusal trauma? And here, they're definitely layered upon each other, but we wanted to sort both things out. So first of all, we did do our stabilization, of course, and this was Basra once we had cleaned up the gums. As you can see, what a result. Massive, massive improvement. We have had 2 root canal treatments done. You can see the apical pathology on the upper right 4 has now fully healed. We've addressed the caries. And now we're ready to remove the traumatic occlusion. So what you'll notice is if I show you the occlusal views, actually we still do have a little bit of inflammation on just the distal palatal portion of that upper right one, and that's where the fremitus is hitting over and over again. So we have a look and we say, right, so we've got fremitus on the upper centrals. So our main concern, our main aim for this treatment from our point of view is to remove the traumatic occlusion. The main aim for Basra is to give her confidence back. She's got more confidence because she now knows that her teeth are feeling healthier. She knows that they don't smell. But, if you can imagine what it feels like to not be able to close your mouth properly when you're in company, to not be able to talk comfortably. And actually, if we had said to Basra right at the start, no, you can never have orthodontic treatment, don't be ridiculous, it's definitely not suitable for you, would she have gone through that stabilization phase? Because, with patients, we have the carrot and we have the stick. So actually having that carrot there means that, patients feel motivated because they can see the light at the end of the tunnel, because we're still going to give them what they want. We just have to get them to where we're happy to give them what they want. And that meant a little bit more stabilization, a little bit more health associated with what was going on in Basra's mouth. So we want to make Basra happy, but we also need to make sure that we are working hard to stabilize the bite, get proper occlusal contacts. And I like on the anterior teeth to just be able to have shim stock being able to be pulled through. So you can see here, you'll notice that in the end, we did actually remove a lower incisor, because we had 90% bone loss. You can see there's some nice big attachments on those laterals because I'm using those to pull the upper centrals down, so to retrocline them. They've got to do a lot of movement, and you'll notice that there is a larger amount of aligners here, 40 aligners. This is because I've used minimal velocity so that each stage of the movement is reduced. So there's less force per aligner. And we've also got class 2 elastics in so that we're sharing the anchorage between the upper molars and the lower molars. So you can see intrusion of the upper anterior teeth, correction of that deep bite, retraction, and space closure. Okay. And then we can see that's where we were aiming to end by the end of the alignment. So you can see just how much proclination, or just how proclined those upper central incisors really were. They're almost at 90 degrees, and we are intruding and uprighting at the same time so that we can end here. And this is where we ended up. No fremitus. We've got equal bilateral simultaneous contacts posteriorly. Anteriorly, we can pull shim stock through when she's biting lightly, so that we don't have hard anterior contacts. We've got fixed retention in the lower because we still have reduced alveolar support, and we removed a tooth. In the upper, The problem with upper retainers, if there's not space for an upper retainer, we can create a hard contact, and also it can push the mandible back and up, and that can cause problems in the TMJ. So we decided not to put one in the upper arch. We know we've got the good occlusal contacts. We're retaining with the Vivera overnight anyway, and so we're happy. And actually, I saw Basra 2 weeks ago, and everything's looking really lovely. And of course, she was so dedicated from when I first saw her to when we finished was about 2.5 years worth of treatment. Not all aligners, actually the aligners part was the smallest part, the shortest part, but the stabilization took the longest. But the stabilization didn't end just with the treatment of the periodontal disease. We needed to get that stable occlusion. And you can see in her face, if you look at her eyes, how she holds her face, it really is wonderful to see. And I think you can just see the brightness in someone's eyes once they're happy with their smile, once they're confident. And not only that, but from a functional point of view, she's got an increased lower face height. Okay. But you can, if you look on the pre-op photo, look how hard her chin is working to get up, to get into, to get some oral seal. Whereas while she still has a little bit of tension in her chin because of the increased lower face height, actually you can see that's much more relaxed, not having to jut out her lower lip. And one of the nice things is, she doesn't feel embarrassed when she's teaching. She's sleeping better and she feels much better in general. And she's really turned her oral health and her oral ability, or her ability to make those decisions for health-related change, into a positive light. She is sleeping better, she's eating better, she's feeling better, and she's just so much more confident. And this is one of the real amazing things that we can do with clear aligners and orthodontic treatment, is that we can create health-related behavioral change. One, because the patient sees us a lot, so we can impart information over and over and over again. Also, because the patient feels more comfortable with their smile, with their teeth, and they understand what they're meant to do. And not only is this a physical change, but there's also an improved perceived ability. So it's also a mentality that not only can they clean their teeth better, but they think they can clean their teeth better, or they think they can maintain a better diet. And so we give that positivity and that mindset to the patient, just, and I put just in inverted commas, by making sure their teeth are in the right position and working as they should be. So what else can we give the patient? So let's look at Jonathan. Jonathan came to see me because he didn't like the upper right one. And I think we can all see the upper right one is very twisted. But what else can we see? Who can see those great big buccal tori? They're sort of jutting out there. And we also have those lingual tori. I mean, Jonathan is really going to town on his teeth. And yes, I would say the alignment is going to be important here, but ultimately, I really want to make sure that we're protecting these teeth from any further damage. We're into dentine. He's mid-30s. And so we want to get the teeth aligned because that's his aesthetic concern. But at the same time, I'm talking to Jonathan about his parafunctional behavior and how ideally I really want to be protecting these teeth. Now, we know that we can't stop parafunction. We can reduce the intensity of the muscles, but masseter Botox, we can provide splints, but we know that he is likely to carry on that parafunctional behavior going forward. So what can we do to help? And it's a great opportunity for us. So here we're going to align the teeth. You'll see the upper right one coming into position. And what you'll also notice is that we leave space to restore the cuspal tips of the canines and the premolars, and at the canines and the premolars there. So if we look here, you can see we've got the space. I'm still going to be leaving him canine guided. That's where I would like him to be. And luckily he's pretty unrestored. So, I'm less concerned about bits of teeth pinging off, but ideally I still want him to be canine guided, just because if he's going to town that much, I would prefer the canines are taking the brunt rather than the premolars. So we go through the aligners, and actually everything moved really beautifully. There is always a little bit of concern that with bruxis, the clear aligners, because we're putting so much pressure through them, they can warp, it can distort the plastic a little bit. So I always warn patients who have bruxism that that may take a little bit longer. Thankfully for Jonathan, he was very compliant, so we moved quite well, quite quickly through, and we aligned the teeth, and then we restored. And the only tooth that doesn't have composite is the upper left tooth. That's the only tooth that got away with it. On top of the alignment, on top of the composite, he also had Botox in his masseters to reduce the intensity of the muscles. So we know he's going to brux, but that's okay because he's not going to do it with quite such furore. And even if he did, and he goes through my composite, which hopefully he won't do because he's got a nice hybrid Essex retainer and B splint. Okay, so it's doing two jobs. He will only be wearing away my composite, and that's okay because we can replace it in the years to come. So you can see all the cusp tips have been restored there. Just freehand composite at the end, and then I just balance the occlusion on the same appointment, making sure that we had those bilateral simultaneous contacts posterior and ICP, and also that we're in guidance. Most of the brunt is being taken by the canines, so you'll see they've got slightly steeper guidance on the canines there. So we go from start to finish. And the interesting thing about Jonathan is that even though he came in with an aesthetic concern, because of the education, because of the discussions we had, and I think probably he picked up on, I was a little worried about his tooth wear. Actually, at the end, whilst he's happy with how everything looks, he's main feedback was that he doesn't have to worry about destroying his teeth, and he's now not worried that he's going to lose them, they're going to break, and he feels comfortable. So yes, he is still bruxing most likely, but he feels less stressed about the stress of his teeth, and they look good. So again, it's that giving him that carrot of getting what he wants so he can feel comfortable and happy, and then also making sure that us as dentists are looking after the health of the teeth. And giving someone the ability to maintain better oral health with relatively little maintenance, so just wearing retainers, is such a wonderful gift. What else can we give a patient? We know that every time we do restoration, and whether it's a filling, an onlay, implant, root canal, at some stage that's probably going to need to be revisited, redone, or it's going to fail. If the patient wears their retainers, and that is a big if, I know, we can give them long-standing oral health, not only from a tooth wear point of view, but from an ability to keep their teeth clean with very little maintenance. And we get improved aesthetics, which is important for the patient and for us, but also that increased or improved function. And with Jonathan, you can see that was very parafunctional behavior, but a lot of the time we see this constricted envelope of function in class 2, division 2 patients. We see this thinning and wearing on the upper and lower anterior teeth. And actually, if we just position the teeth better, we could stop that. And we can reduce plaque accumulations by getting the teeth into the correct place. So we've spoken about sort of the physical side of things, but what about the psychosocial? So Olivia, again, similar to Basra, was really embarrassed of her teeth. She was quite an energetic person. She was an extrovert. She was very chatty. She was quite a social person, but she was very embarrassed about her teeth. We can see that, yes, she has crowding. She has some gingivitis, so we can see some gingivitis there, especially around those lower anterior teeth. And she also has a very narrow arch form, so we can see the upper arch form has collapsed. We've got lots of crowding in the lower arch. And the problem is that when we want to create space, when I want to relieve this crowding, ideally we want to have a little bit of expansion there. But here we can see we've got a very thin biotype. And the problem is if you've got a very thin biotype and we can't expand, then we need to find another way of creating the space. And often this ends up being IPR. And whilst I think IPR is a great tool to have, it's not something that I like to overuse, because one, we're not very accurate with how we do it. We tend to underdo it, and that compounds and affects the effectiveness of the treatment. And actually, when I look at the movements here, yes, we do want a little bit of relieving the crowding, but even if I use lots of IPR, we're not going to be able to relieve this much crowding, especially in the lower arch. So actually what we decided to do is we decided to distalize. So we decided to push the upper anterior teeth back and distalize the molars, then the premolars, then the canines, and so the upper anterior teeth could come into place, because she's a very class 2 division 1 malocclusion. So we want to align the lower teeth and pull back the upper anterior teeth. So smaller attachments here. You can see we've got class 2 elastics and IPR still in the lower arch. So you can see the molars going back there. And now the premolars are going. We're using medium anchorage. Canines are tucking in. And the upper anterior teeth are now able to align. And as they're aligning, they're slightly retracting. You can still see we're using a lot of IPR in the lower arch. But what's really important here is that we didn't overexpand. I know lots of people want that nice wide smile, but if we had overexpanded, then we would have created more recession. And my problem with creating recession is that one, it's very unaesthetic, and also it's unpredictable. We don't know when it's going to stop. And it often means that the patient needs to have surgery at some point in their life to stop it. So this is where we ended up. You can see we've got nice posterior occlusion, nice aligned anterior teeth. Overjet has been reduced. And we haven't made the recession worse on any tooth. So we've got nice alignment. You can see that the premolars are still sitting within the alveolar bone. You haven't sort of overexpanded everything. One, it causes recession. Also, it's very unstable. The teeth don't want to be sort of half hanging out of the bone. So we tend to see that relapses quite quickly. Yes, we've got a little black triangle in the center. I always warn patients about black triangles. So you can see that Olivia's teeth were very triangular to begin with. So, and I warn them about it. I say we can use composite. We can plan in some IPR if need be, but there's no health risk. It's an aesthetic concern, and sometimes we'll get the papilla infill over a little while anyway. And the nice thing about Olivia is that we got a really nice result from the function, from the aesthetics, but from her point of view, actually what was so special is the psychosocial. She now feels that her teeth represent how she wants to show herself to the world, and what she came back and I see my patients always after a year of treatment, just for their final sort of review with me before they go back to their general dentist. And she said she could concentrate on meeting her niece for the first time and not worrying about how her teeth looked in the photos. So she met her niece for the first time, and ordinarily she would be so worried about where the cameras were, she wouldn't be able to focus in the moment. But because she was pleased and happy and confident with where her teeth were, actually she didn't need to worry about where the camera was. She could just be present in the moment and meet that niece. And I think when we think about what the impact of our jobs, the impact of what we do goes far beyond, what we actually do in the room. We don't know just how far those ripples go, because the psychosocial influences are incredible. And so this is what I mean when we really focus on the teeth. Sometimes actually looking beyond the teeth gives us a better sense of job satisfaction and makes us understand and appreciate just how important the work that we do is. We can enhance confidence, self-esteem, and give people better social interactions. Think about what that can do for someone's life in terms of their job prospects, their college prospects, their family prospects. I find it really exciting, and I get very, very emotional and very just happy watching that happen as we're talking to patients and as they come back and share those stories. But how do we start? How do we know to even have the conversation? Because a lot of the time, and how I used to work, is I would do a quick checkup And then I would talk to the patient about their caries, and I'll talk to the patient about their gum disease. And I'd be like, and are you worried about how your teeth look? Because that would be sort of my way in to talk about ortho, because I thought patients would really only talk to me about ortho if it was to do with how they felt their smile looked. And what that meant is that if they said yes, I'd have to get them back in to do an ortho assessment. And actually, sometimes I do the ortho assessment and be like, gosh, actually, this is a much more difficult case than I thought it would be. And, you know, by that stage, you've sort of got yourself one step further. So what it also means is that if we're doing a checkup and we're not looking at more than sort of the individual teeth, it means we can miss looking at the mouth as a whole. And actually, if we don't ask the patient what their goal is for their mouth, how do we know how do we know what the patient wants, or how do we know what the patient will do in order to get what they want? So actually, when I think about what I do now, which is so different to what I used to do and allows me to be a better dentist and to serve my patients better, is to do a great assessment which encompasses all the ortho side of things for every single patient. And I can feel what you're all thinking, going, gosh, that must take hours. And think of the notes you have to write and blah, blah, blah. And I agree. To begin with, it did take me a long time. When you get into the groove of it, even the physical, checkup doesn't take that much longer, because it's like anything. The more we do it, the better we get and the quicker we get. So we're going to go through a quick assessment, and then we are going to look at Kiroku and how we can utilize it to make our assessments really quite efficient, and making sure that we are capturing everything we need to capture for every patient. Because what's really good is it doesn't just save time on the day. It means I don't have to get the patient back. It means that when I'm talking to the patient, the first thing that, I'm not trying to think about, okay, well, I'll need to do this, this, and this, because I already have all that information in front of me to talk to the patient through with. So if we look at the skeletal base and the smile, and my assessment is based on the SAFE assessment, which was created by Dr. Raman. And over the years, as you use something, you ever so slightly tweak it, but has the same basis, and it's to do with facially driven treatment planning. So the first thing I look at is the skeletal class, and this is really important for our diagnosis, because if someone has a skeletal problem, it is going to be much more difficult, if not impossible, for us to fix from a dental point of view without orthodontic surgery. So this is crucial for me to understand right from the very beginning, because otherwise, how do I know where my limitations lie in what I can offer them? So skeletal class. And the thing is that the reason I'm doing this for every patient is because I only will do this fully for the first time I meet a patient. If it's a patient who I see every 6 months or every year, we will do a filtered down version of this, because we've got the baseline, and I'll probably repeat it every couple of years, because we need that really thorough baseline. So we want to look if they're a class 3, class 1, or class 2 skeletal. Another really important thing, upper midline. Even if they're not going to have orthodontic treatment, it's good for us to know where the midlines are. And I will look at the upper, lower, and chin point midlines as well, because if something is changing, this is going to give us clues as to when it started changing. So midlines, we want ideally a midline that's upright, parallel with the facial midline. What you'll notice is that someone who has a canted midline is much more obvious to the eye. We tend to like things that are straight. So a midline that's off to the left or to the right, but is parallel to the facial midline, looks more harmonious than a midline that's in the correct place, but that's canted to one side. So we want to think about the smile line. So how much gum can we see when the patient smiles? And I actually quite like a slightly gummier smile. I like to be able to see a bit of gum. It's more natural for females to show a bit more gum than males, but I like to be able to see, maybe 5%. A millimeter or so of gingiva above the centrals. To me, that's what look looks aesthetic. But of course, this is then a conversation we're having with the patient, especially if they want to go ahead with some treatment about what they like. Because again, one of the traps I used to fall into is that I would give patients aesthetics that I liked, and maybe it wasn't necessarily what the patient liked. We want to think about those buccal corridors. Most patients really want that nice wide smile. So is their buccal corridor full? Is it deficient? Again, over time, if we think about seeing our patients over an extended period of time, and what this information can do is that over time, our arch forms tend to collapse. And so if we have, say, records showing that they had a full and now they've got a normal buccal corridors and actually it's becoming slightly deficient, we can show the patient that there is a change. We can show them what's happening to their mouth, and therefore we can talk to them about what that impact is having on the facial structures intraorally in terms of crowding and what that means long term. Looking at the smile arc, so thinking about where do the incisal edges of the upper anterior teeth fit. Ideally, we want that arc, if we go canine tip all the way through to canine tip, to follow the shape of the lower lip. And you can see here that actually this is quite a flat smile arc. Ideally, we want it curved. We want it to follow the shape of the lower lip there, so that nice curvature. Some people do have asymmetries. That's absolutely fine. You can talk to the patient about their facial asymmetry in terms of the smile. It may be that actually they're not that bothered by it, and then you just carry the curve round. It may be that perhaps you want to refer to or utilize yourself some facial aesthetics to balance out the position of the lower lip there. And one of the things that I find most important is the nasolabial angle. So we want to have an angle of about 90 to 120 degrees between the base of the nose and the upper lip. This gives us a good amount of upper lip support, and again, is what would be considered looking to look the most aesthetic. If we have an obtuse nasolabial angle, so if that angle is too big, then it can make the nose look overlarged and the lips can look quite thin. Now, this is really important if we're doing any retraction of those upper anterior teeth, because the lip sits on the upper anterior teeth. So if we retract the upper anterior teeth and we've got an obtuse nasolabial angle, we're going to make that worse, and it can prematurely age the patient. However, if we have an acute nasolabial angle and do a bit of retraction, we're probably going to not have such a negative effect. And actually, as you can see here on the left-hand side picture, we look a little bit too full. So a little bit of retraction there is just going to let the upper lip sit a little bit nicer, because you can see, because she is class 2, but we really want the lower lip to sit slightly in front of the upper lip, ideally. And then let's think about our teeth. What shape are the teeth? Of course, when we're thinking about our tooth shape, different people have different shaped teeth. Different shapes mean different things. So if we have very square teeth, it may be that the patient wants to add some length. They might look quite short and squat. I quite like oval teeth, although I like them a little bit squared as well. So we what we'd call a squoval tooth. So slightly squared on the distal and mesial, but generally slightly round. Triangular teeth, more at risk of black triangles. Rectangular teeth, typically what we would call ideal, but they've got long contact areas. So if you were to do any IPR there, that's going to be more challenging for you, whereas a triangular tooth can be easier to do the IPR on then. And thinking about our tooth size and our harmony. So do we have good height to width ratios? And do we have good ratios between the centrals, the laterals, and the canines? I think we can all agree that in this photo, that upper lateral is huge, and the upper canine actually isn't a canine, it's a premolar that we want to change to look like a canine. But what was difficult about this case is that there is the impacted canine still present, hanging around just distal of that upper right to there under the bone, and actually started to cause some resorption. So what we would, was part of your assessment, obviously we have what we can see in the mouth, but then we also have our radiographic as well to give us that extra layer of knowledge. And before we move on, a good full TMJ assessment. So I like to test to see if the joints can be loaded. So can they withstand having being put under pressure with a load? So is there any inflammation? Are there pains, clicks? If there are clicks, is it single, multiple? Are they opening, on closing? Is it right on the left? And I also like to register maximum and normal opening, because again, as a baseline of information, this is really important for us to have on our patients. So our classifications, and I know it can feel a little laborious to do our classifications for all our patients, but again, you never know which patient is going to turn around after 3 months and be like, actually, yeah, no, I really would like to go ahead with that orthodontic treatment, or perhaps, they have an accident and you're having to do some more full mouth rehabilitation. And understanding what they had before is going to make everything a lot easier, and also easier to spot changes. So overjet, positive or negative. And remember, the overjet is the horizontal distance between the labia of the lower and the labia of the upper. It is different from vertical incisal clearance, which is the labia of the lower to the palatal of the upper. And then we have got our incisal classification, class 1, class 2, division 1, class 2, division 2, and class 3. Now, it's all to do with where the lower anterior teeth sit in terms of the cingulum of the upper anterior teeth. If they sit on the cingulum of the upper anterior teeth, that's class 1. If they sit behind the cingulum of the upper anterior teeth, that's class 2. And then remember, class 2 is further differentiated between division 1, which is a normal or proclined upper incisors. Division 2 is retroclined upper incisors. And then if the lower anterior teeth sit in front of the cingulum, that's a class 3. And what that means is that a class 3 doesn't necessarily mean a reverse overjet. It can still have a positive overjet, but the lower incisors are occluding in front of the cingulum of those upper anterior teeth. Now, we also need to know our molars and canines. So molar classification, we're thinking about the relationship of the tip, the mesial buccal cusp of the upper first molar, and the buccal groove of the lower first molar. So in a class 1, everything sits in nicely, okay? So the mesial buccal cusp of the upper first molar sits into the groove of the lower first molar. And what you'll notice is that if you look to the third picture, that actually in a class 2, everything intercuspates quite nicely as well, if it's a full unit. So if it's everything sort of shifts the full unit into a class 2 or to a class 3, actually we still get good intercuspation. It's when we get half units or quarter units, class 2, class 3, that's when we can see some cusp to cusp occlusions. And generally speaking, they are less stable than if we have a full unit class 2, a class 1, or a full unit class 3. I like to think of class 2s as being in front. So notice that the tip of the mesial buccal cusp of the upper first molar is sitting in front of the groove of the lower first molar. And in a class 3, it's sitting behind. So I think of class 2 as in front and class 3 as behind. Canine relationship, the cusp tip of the upper canine into the embrasure of the lower canine and the lower first premolar. Again, class 2 is going to sit in front of that embrasure. Class 3, the cusp tip of the upper canine is going to sit behind. Okay, so that class 2 moving forward, that class 3 moving back. We want to think about our vertical overlap, so our overbite and open bites. So our overbite is how much of the lower anterior teeth are overlapped by the upper anterior teeth, and ideally we want about 30%. Okay, anything more than that is a deep bite, anything less than that is a reduced bite. If we have no vertical overlap, then that is an open bite. The problem we can see if we've got a very deep bite is that we have an extended guidance. Okay, and depending on the angulation of those upper anterior teeth, we can have a restricted or constricted envelope of function, and we can see tooth wear there. We also want to see if there's any transverse problems, and these are cross bites. So do we have the, we normally would see the upper teeth sitting outside of the lower teeth. Sometimes that's crossed partially, okay? And sometimes that's fully crossed, like in a scissor bite. And then, of course, looking at the overall arch form. Ideally, we want a U shape, but we can see a V shape. Normally, they're associated with quite narrow palates. Square, I typically see in class 2 patients, especially class 2 division 2. And a mega is if we have this sort of bell shape. So we have, it goes in around the premolars, first molars, and then comes out again. Most patients want a nice U-shaped arch. I've only ever once been asked by a patient to keep a square arch form. And that's because she really enjoyed looking at that square arch form. She liked that squareness. It was actually quite difficult to achieve because you keep wanting to make it U-shaped in your mind when you're setting things up. But we did achieve it, and she was happy in the end. Great. So, and then we look at pathology. And to be honest, this is where our normal checkup comes into place. So we have our BPE, we do all our charting, our caries, root field recession, biotype, apical pathology, oral hygiene, tooth surface loss. And I'll also do tooth color as well. I will measure the anterior teeth. And we're doing a full good checkup at the same time. And it always feels, this is what I used to do as my checkup. And now I do everything else at the same time, because what this allows me to do is allows me to have a really good conversation with the patient. Because actually the first thing I speak to the patient about now isn't have they had any problems with their teeth, because patients, they go, oh, yes, I had something last week, but now it's gone. Or, yes, I woke up this morning with a problem and blah, blah, blah. Or, yes, I had a problem a few months ago. What I ask them is, what are their aims for their teeth? What do they want long-term for their teeth? And some people say they want an improvement in appearance. Some people will say they want to maintain the teeth as they are now. Sometimes they will say, I want to spend as little time at the dentist as possible. And what that allows us to do is it allows us to take all the information that we've just collected from the patient, extra oral, moving all the way intraoral. So one, they feel like that we've really looked at them. We haven't just gone round quickly in 2 minutes. We've felt their joints. We've looked at their soft tissues. We've looked at the teeth. We've looked at how the teeth work together, not just statically, but how they're working together. And then we can recommend treatment that will match with what they want, with their why, what they want to achieve, and what their long-term goals are of their mouth. And it's a very strange question that patients get asked, because they've probably never been asked it before. Because, for instance, if someone says that they want to maintain their teeth for as long as possible, but when you look in their mouth, they have wear on the palatal aspects of the upper anterior teeth, and they've got wear on the lower labial surfaces, and they're a class 2 division 2, and you've noticed this because you've looked at the mouth as a whole and you've done a full assessment, then you can say, look, I know you said you want to maintain your teeth, but I'm seeing this tooth wear. Have you noticed it? This is going to continue. Here are the options that we have in order to achieve your goal of maintaining your teeth for as long as possible. And all of a sudden, it becomes a very different conversation. It's not a conversation of, this is what I can see, this is what I think we should do. It's a conversation of, this is what you told me you want, this is what I can see, this is how I can help you achieve what you want, what you told me you wanted to achieve at the very beginning. And it works really well. The patients feel involved and they feel empowered, and it allows us to do different treatments for our patients and keeping in mind what their values are. Now, the problem with having doing a good assessment or a more thorough assessment is that it takes a while. And it takes a while not just to do the assessment, but then to write it all up. Because historically, we use templates that we delete from. And it's really time consuming. And our nurses don't do it because they're probably, because our assessments are a bit complex. It probably hasn't been laid out very well in the templates, whether we're using SOE, R4 or dentally. And we forget to delete something. So then it's not accurate. And actually that doesn't protect us. And it can be really difficult to read. And it takes ages. I know exactly how it feels once you've done this assessment. The patient leaves and then you've got to spend 15 minutes writing your notes after a checkup, and it's exhausting. And I think, if I'm very honest with myself, where I used to do a shorter checkup is because it meant I had to write less notes. There was less admin afterwards, and I was doing what I could for the patient with the time I was given, because that admin side of things was taking so much of my lifeblood, my ability to be there for patients. And it really, concerns me is how safe are we legally when we're using that. And then I was very lucky, and whilst this webinar has been put on with Kiroku, so you all might think I'm slightly biased, and truthfully I am slightly biased, but I'm only biased because I use it every day, and it honestly has changed my life. And every person I speak to and everyone who's on my program, I encourage them to go and use Kiroku because it had such a profound impact on my life and how I do dentistry. And I'm going to show you the workflow going through my normal assessment now. So what you'll see is, hopefully, there you go. What you'll see is patient's complaint, and then we're filling everything in. And it's so quick. And the beauty of this is that I'm not even filling this in. This is my nurse who's filling this in as I'm talking to the patient. So I'm talking to the patient face to face. My nurse is behind and she is clicking the buttons as we go through. And I know how the assessment goes. My nurse is there reading it, and it's so quick and easy. Now, what happens is that you're doing your assessment, you are really talking to the patient, you're focusing on the patient, and you're creating all these really quite significant notes and detailed notes for the patient without having to go back and forth, write things down, because the nurse is doing everything for us. And it means that by the end of the appointment, our notes are written for us. Other great things that I like is that you can add different parts, you can edit things. If you're not happy with one of the selections it's given you, you can go back and choose something else, and you can save it to drafts. Okay, now I save it to drafts not so that I can go home and finish all my notes, but I do save it to drafts from when I used to use sort of note systems that you couldn't access remotely, and it's all anonymized so that I could plan cases, write treatment plan letters at home as well. So we can see going through all the different points of the assessment. And it's all creating lists, and it's very nicely laid out, and it's really easy because it's web-based. You can access it on your laptop, or you can access it on the work computer. And so some of my nurses feel better doing it on the computer, like some of them like to do it on the laptop, whichever they prefer. And what's really nice is that it creates a problem list for me. Now, this problem list is created anything that deviates from the norm, and this is something that me and the guys at Kiroku set up. And so anything that deviates from the norm, we can have a look. And then this is my conversation point with the patient. What are we going to accept? What are we going to improve? What are we going to correct? It brings up the diagnoses, so the health points, and it also helps fill in the discussion. So you don't forget to talk to the patient about something because it's written there for you. And you can add to what you've spoken to the patient about, or take it away if you didn't speak to them about it, for instance. And you can see that when we have different options for treatment, you can fill in different options and then give what the patient opts for. So what it means is that everything is very streamlined. It's not us taking away, it's us adding, which means that we can't forget to remove something. So our notes are actually much more accurate, and they're much more, they protect us legally. So we can see in the case of this patient what they wanted to go for in terms of cosmetics, how long we said it was going to take, what the cost was going to be, talking about what general risks we went through. And then any specific risks. So if they've got centerlines, if they've got recession, if they have a root canal treatment that might flare up, anything that we're concerned about. And then again, what did the patient say they want to do? So ultimately, what really happens is I have to fill in that last little bit because everything else is already filled in. And I just fill in the bit after the discussion, what we've actually agreed with the patient. And then we put in our next steps, so appointments for stabilization, health document sent, and information pack. And the beauty of it is you then just copy and paste it. So you copy and paste it into your notes, and it's there, and it stays in that same format. So it looks nice, it reads well, and it follows how you've done your assessment. Now, as Hannah said, what's really exciting is that it's now gone one step further. So you've got the Pro Tools, and what that means is that if you press Pro Tools and you go into a letter, a preformed letter or preformed template letter, it will then fill in parts from the assessment. So for instance, one of my letters is all to do with the sort of primary disease and the health, and it goes through what we need to do to get the patient back to full health, and it fills it in based on what the assessment has said. So for instance, if we have chosen in the assessment that actually there's no gingival inflammation, it's not going to put into that document that there's gingival inflammation. But if we have said there's gingival inflammation, it will say there's gingival inflammation, we would advise an appointment with the hygienist, and it goes through the risk and benefit, what I would normally put into my treatment plan letter. But now, instead of me having to copy and paste different sections of my treatment plan letter and edit them manually, now it does it for me. And I also have one for a consent letter for orthodontic treatment. I've got a consent letter for sort of whitening, things like that. And then I also have sort of a summaries. So if the patient, like Basra, who we saw earlier, has lots of health things that we need to deal with first, then I will write the full letter with the health, and at the end also, the aesthetic and orthodontic treatment that will come later. But then I will give her a summary of what we discussed with the orthodontic treatment. And so it doesn't go into full detail about that because it's not relevant just this second, but I know it's going to come later. So it means that she has a really good follow-on on what she can expect from her treatment. So we bring all that information together, and it means that I don't miss talking to the patient about something. And I like to talk to the patient with the photos, the scan, and I will also have the problem list open, and the problem list is written. I don't have to think about, oh gosh, what did I see earlier? And was that a class 2 or was that a class 3? It's all written there nicely for me because me and my nurse have done it as we're going through. It means actually writing my notes takes a couple of minutes, even though I'm gathering all of that information. So we get to involve the patient in our findings and create goals together. And we know that co-diagnosis, co-treatment planning really fosters a much better compliance and uptake of treatment, especially when we relate it all back to their why. So hopefully you've seen today how clear aligner therapy can really enable us to reach very nice outcomes for our patients, not just in the here and now, but also long term. We can also ensure that by doing good, thorough assessments, we're able to offer our patients the correct treatments that suit them and the correct options for them. And record taking does not need to be consuming or difficult. With tools or with Kiroku, it means that we can actually be very efficient, very effective, very thorough without having to spend hours and hours and hours. I always like to finish on this slide that you are the hero of your own story, and I really believe that, so you can go out and make all the changes that you want for yourself, and then you can also enable your patients to choose the right options for them so they can also be the hero of their own story. Thank you so much for listening. If you want to keep in touch, please do. And I believe we have a little bit of time for some questions. So I'm just going to come out of this and stop sharing so we can answer some questions.
Millie, thank you so much. That was awesome. I definitely took loads of learnings away from that. Ironically, you can see from my talk that I'm actually in practice this evening, was seeing a clearer line of patients. So definitely always worthwhile learning more. I've got a couple of questions which I can read out for you. So do you have radiographs with bone levels before the treatment with aligner started, and periodontal charts? 2 parts of one question.
Yes, absolutely. Sorry, you can see my dog's nose just in the corner there as he's decided he wants my attention now. So yes, absolutely. I like to take OPGs as standard before we do any orthodontic movement. I will also take bite wings, and I will also take PAs if I need to. And sometimes I will take lateral kefs, and sometimes I will take CT scans. So when we're taking radiographs, remember, anything that can change our treatment is a justification. And most of the time, obviously we always want to keep it as low as reasonably possible, but sometimes we do need those further investigations. So yes, absolutely. I always want to see the bone levels before we start treatment. Not only do I want to see the bone levels, I want to make sure that the perio is stable. So yes, we'll do the BPE as a screening tool. And if we're worried and we need to do more charting, then we'll do a full periodontal chart. Because if we start moving teeth when the periodontal disease isn't well controlled, then we can accelerate bone loss. So yes, to both questions, yes.
Next question, actually, this is one I'm glad that this person has asked, because I wanted to ask about it as well. Can you talk a bit more about retainer with B-splint?
Yeah, absolutely. So I get it's a hybrid splint that I get from Hanham Dental Lab, Hanham. And so it's sort of an Essex retainer, but it has the platform for the B splint. So it means that it is retaining the teeth, but because it has that anterior plane, which we see in our B splints, it means that if the patient is parafunctioning, they're sliding around on that anterior plane and they're not sort of gripping tightly posteriorly.
Great. We've then got a couple of questions which I'm going to have to... So could you please share your Kiroku templates assessment? Would you be happy to share that? That's from a couple of people. So I'll leave that to you on how you want to answer that.
So there are definitely templates that I have made on Kiroku available. So we have the safe assessment. That particular template is available to people who are on my program. But I have to say the templates that are there that are available to everyone are that just in a slightly different order. So yes, absolutely, you can access those, and I think you can do that just with the safe codes, right, Hannah?
So to anyone who is on the safe courses, you should have access to that. If not, you should actually still have access to loads of generally available templates, and you'll be able to access that in the Invisalign assessment within the template library. And if you do access those, I hope... Is my internet dropping out?
No, it's okay.
Good. If you do access those, that does also generate a problem list as well. So yeah, please do have a go with that, everyone who's interested. Another question about the template. And then does Kiroku help formulate consent letters? I mean, I'm very happy to have the stab at this question. Millie, jump in if there's anything to add. But with Kiroku Docs, if you are a Kiroku Pro customer, you'll be able to create any type of document from a template. But what we have created and what's available again on the template library is a full treatment planning letter from Invisalign assessments, from Invisalign treatments, and we've got that built into almost every assessment and every treatment. So please do have a play around, and if you haven't used Kiroku before, do sign up for the free trial onto Pro so you can have a full play around with everything that's available. Millie, please jump in if there's anything to add there.
So no, I think what we have to remember is that consent isn't one letter that we send the patient. Consent should be continuous, and it happens at each appointment. And actually, by doing that good assessment and by going through the problem list, you are consenting the patient much better than you probably ever had before. And I think that sometimes we think of consent as like a chore that we have to do. And actually, because we're like, well, that's the way we protect ourselves. And I do agree. However, my feelings about it has changed, because what I've realized is a better consented patient not only protects us better and protects the patient better, but it leads to a much better journey as well for the patient, because you get a much better rapport. There's no surprises for them. And when they know something's going to happen, and if it does happen, well, they knew it was going to happen and they accepted that risk right at the start. And therefore, there's no sort of embarrassment or umming and ahhing about how we're going to fix it. They jump in. So, that side of consent still needs to happen, and Kiroku helps you at different levels, because it helps you, one, take a really good assessment where you don't forget anything. It also then helps create the problem list, so that's your talking points with the patient, and then it can go that step further and helps you create that document, which is a summary of all the discussions you've already had. So yes, it helps you formulate consent on multiple different levels, I believe, anyway. And the docs are sort of the cherry on top, because now it's just so easy.
I'm so pleased to hear that. We've got another question, which is, do you just ignore Invisalign's consent form
And just
use your own?
So I think when I first started out, I definitely used Invisalign's consent form, because I had no idea what consent I should be doing or using or talking to patients about. It's thrown in there if you haven't done ortho before. And then what happens is you go on courses, you learn more, and you go, gosh, I need to put more in my consent form. And then something goes wrong, or the patient didn't really understand what you had said. So you're like, gosh, I need to make that clearer. And then what evolves and what develops is your own very personal consent form that follows how you talk to the patient and follows your patient journey that bit better. So actually, I think, Marcus, you asked that question. My consent form started from Invisalign's consent form, but it's evolved into a completely different creature based on the last few years of working with clear aligners.
Perfect. Thank you. Another question about templates being available. Hopefully we've already answered that one. We've got a question from a dentist who said, I currently offer ClearCorrect. Where can I find out more about safe aligners, or maybe do the training?
So the best place to go to find out more about SAFE is the Aligner Dental Academy. So that is I always describe it as Facebook for dentists, and it's a fantastic platform. There's lots of learning. It is generally based towards Invisalign. However, once you understand the biomechanics, you can apply that to the different systems. And actually, we should all fundamentally be starting from doing good assessments and understanding the biomechanics and understanding, how to treatment plan correctly, no matter what system we're using. It's like, how do we, we don't diagnose a filling just because we want to use composite. We diagnose caries. We think, do we need a filling or an onlay or an extraction? And then if composite is the best material, then we decide what type of material we're using. So I would jump onto the Aligner Dental Academy and have a good look through there. There's tons of resources to help you on your journey.
Perfect. And then we've got a couple of just general thank yous. We've got one question which is asking about the Kiroku DFT offer. If you've got any queries about whether your scheme is eligible, if it's not the kind of traditional DFT, please just message the team through the platform. And if we can verify it, we will do. So please reach out to us. Do you have consent templates for composite bonding? I'm not sure if that's a question to you or to me. I will answer from Kiroku's perspective, which is, I don't actually think we have composite bonding from an aesthetic perspective, but if you do have any templates that you want us to build that aren't on the template library, which I think are pretty few and far between, but to my knowledge, I don't think composite bonding is on there, please just send us a template that you have and our dental team will create your templates for you. So we can just recreate your existing process, but add some Kiroku superpowers to it. Okay, there's actually, I think from one of the questions, bear with me. Sorry, trying to read them, but I'm just struggling to get to the questions. I thought I saw one. But no, I think there's lots of thank yous. Yeah, so thank you. I think that's all the questions.
Brilliant. Well, thank you so much, Hannah, and thank you so much, everyone, for being here tonight. It's been an absolute pleasure. Thank you, Lisa, in the background, who's doing a fantastic job as ever, making sure we all run to time. And Hannah, I'm sure you want to jump home so you can relax after a long day in practice.
Thank you, Millie. Thank you for an informative and interesting talk as ever. I learned a lot, and thank you to everyone for attending. And just once again, if anyone is interested in giving Kiroku a go, just sign up at the website, try Kiroku.com. You can have a free trial. Any questions at all, please reach out to the dental team because we'll do everything we can to help. Millie, thank you again.
Brilliant. Thank you so much, everyone. Bye-bye.
Bye-bye.